Hello, everyone, and welcome to the webinar series on the social protection responses to COVID-19. My name is James Fitzgerald. I'm the Director of Health Systems and Services here at the Pan American Health Organization, which is the regional office for the World Health Organization based out of Washington, D.C. It's a pleasure to be able to moderate this session we have this morning on universal health coverage and the coronavirus, challenges and responses, with a particular lens on looking at maintaining essential health services while responding to COVID-19. This is actually the 10th webinar of the Social Protection COVID-19 webinar series. It's a joint effort initiated by the IPCIG, the GIZ on behalf of the German Federal Ministry of Economic Development and Cooperation, the BMZ, and the Australian Government's Department of Foreign Affairs and Trade, DFAT, in collaboration with socialprotection.org platform. Obviously, we have other partners here with us today, including UNICEF and our colleagues as well from South Korea and China. The webinar is a part of a much broader initiative which socialprotection.org is leading. It includes a collaborative mapping of country news and documents disseminated weekly through dedicated newsletters, as well as an online community on the topic to systematize information and foster discussion. So feel free to join online social protection responses to COVID-19 to learn more about the whole initiative and to find out how you can collaborate and keep updated about future webinars. So before we start, let me tell you a little bit about the structure of this webinar. We are honored to have with us three global experts and well-experienced professionals that are working in the area of essential health services, each in their particular specialities. We have Dr. Cho Young-jun from the Department of Social and Preventative Medicine, from the University College of Medicine in the Republic of Korea. Dr. Cho is a public health consultant to UNICEF's Seoul office and an assistant professor at the Department of Social and Preventative Medicine in Hallym University College of Medicine, South Korea. He is a pediatrician by profession, subspecializing in infectious diseases at the Seoul National University and the Warren Albert Medical School at Brown University in the United States. Dr. Cho has focused his studies on respiratory virus transmission in the community and the effectiveness and impact of control measures. Our next expert and participant is Dr. Robin Nandy, the Principal Advisor and Chief of Immunizations at UNICEF. He's based in headquarters in UNICEF as of December 2015, but prior to that, he was the Chief of Child Survival and Development in UNICEF Indonesia. He also held positions as a Global Polio Eradication Initiative head at UNICEF headquarters from 2010 to 2011, and has been team lead for health in emergencies in headquarters at UNICEF from 2006 to 2011. Dr. Nandy is a medical epidemiologist and a public health provision. He has worked at the CDC in Atlanta, at the International Rescue Committee, and in the Indian government in the Republic of Maldives. And our third participant is Dr. Wu Wenzhou of the National Immunization Center of China in the Center for Disease Control in the People's Republic of China. Dr. Wenzhou holds a PhD in public health from the Chinese University of Hong Kong and is professor of Chinese Centers for Disease Control and Prevention. He's been working on childhood immunization for many years. Excuse me. He has held permanent positions in the Chinese Center for Disease Control and Prevention, the Ministry of Health, and the Provincial Immunization Program over a period of 8 years. One of the highlights of his professional life has really been to participate in a polio outbreak in the Xinjiang province in 2011 and 2012, and he has published these results in the New England Journal of Medicine. He also serves as an epidemiologist for the World Health Organization in the Ebola emergency response in Sierra Leone for a period of time. These are our participants for today. But before we get started, I wanted to also let you know that following the presentations from our experts, we will actually be having a Q&A session. And this Q&A session will be a rolling Q&A session. We do invite you to present any comments or questions in the chat that you will see as part of the GoToWebinar. It may not be possible for us to get to all of these questions and comments that you have. As we move forward in the Q&A sessions, we will also collect all your questions, and we will review them, we will answer them, and we will ultimately post them to make available the responses that you need. Here you can see to please extend information around this important initiative on Twitter. We have the links here for you. So as we proceed, please engage with us in this important discussion. Okay, so to introduce the actual topic, I wanted to lay a little bit for you the situation in which we find ourselves in. COVID-19, the pandemic and the disease has resulted in an enormous loss of life globally, and it has also affected livelihoods throughout the world. It has impacted our health and our economies as they have shut down as a consequence. If we look at where our health systems are, it has had enormous impact on the first level of care, with high levels of transmission amongst our health workers, with the health workforce being taken from the first level of care and being assigned to the secondary, tertiary level of care, or even within specialized hospitals, impacting the provision of essential health services. Hospital health care has been impacted directly, in particular critical care, where some critical care services have been in fact overwhelmed. We have witnessed lack of PPEs, therapeutics, IVDs, and ventilators within our health systems. And so as we see mortality increase through COVID-19, we also see a significant increase in excess mortality or mortality displacement as a consequence of COVID-19. At the same time, COVID-19 has directly impacted economies. Economies have been forced to reduce or to essentially close. There has been a fiscal and monetary crisis in many countries through the lack of generation of income. And in addition to this, there has been a significant increase in health expenditures as countries mobilize the necessary resources to respond to the epidemic. And there's been an enormous and significant demand for increased levels of social protection for workers and people, in particular vulnerable populations, that cannot survive without a context of actually being employed. And so we see from COVID-19, there is an inextricable interdependency between health, social protection, and social economic development. What we really need is resilient health systems that have the capacity to surge, respond, and address essential health services at the same time. Our mandates, our call towards the achievement of universal health coverage goes some way in addressing this and will be a driver for future health systems transformation in the future. But let me bring it back now to the discussion around essential health services. As countries have built the necessary response capacity to COVID-19, we see that we have really scaled up our ability to detect, trace, isolate, and manage the actual outbreak within the context of a very dynamic health system. But it's extremely important that we do not forget the need for the provision of essential health services. And this is not a false dichotomy. This is not an either-or decision. We have to be able to address the needs in terms of COVID-19 while ensuring provision of essential health services. There is also a misnomer that we should only be focusing on the first level of care. No, essential health services should be provided within the healthcare network, and we should be able to define and structure and reconfigure our health services in a manner that deals with the COVID-19 pandemic while ensuring provision of health services throughout the healthcare network. At the same time, we do need to look at the issue of the first level of care, where our health workers are most vulnerable. Certain modalities are coming online now, as we see countries working towards improving telehealth, teleconsulting, mobile clinics, and other innovative mechanisms, including the use of community health workers to go out and to work within the community to isolate and track and ensure that essential health services are being provided. That is the context I wanted to provide for you here today. Our panelists really come from a broad range of specialities, and it's within the context of South-South cooperation that I think we will be really listening to the broad range of experiences from throughout the world on the issue of COVID-19 and the provision of health services. So without further comment, I'd like to invite Dr. Chu-Young Jun from the Department of Social and Preventative Medicine in the University College of Medicine in the Republic of Korea to provide us with his presentation. Over to you, Dr. Jun.
Thank you, Dr. Fitzgerald. So yes, hi everyone. So good morning, good afternoon, and good evening. My name is Young Jun, and I'd be happy to share some experiences from here in South Korea in regard to the responding to COVID-19 crisis in perspective for the universal health coverage. So most of my talk will be dealing how the UHC has helped out with responding to COVID. Little different from probably the talk in the afterwards, but this will be the main focus of my talk in the next 5 to 7 minutes. Next slide, please. So now it seems that we have flattened the curve since late March to early April. We have been discussing about reopening of the schools recently, and it was originally to start the high school seniors to return to their classes this week, but unfortunately has postponed it one more week because of the resurgence during the last weekend. So anyway, I'm going to walk you through some bits of Korean health system and our UHC coverage that helped us to responding to surge of cases in the middle of February. If you see the slope of the increasing cases in the from February 19th to February 26th, the slope was very steep. So it was very hard for us to respond to this surge capacity into our health system. Next slide, please. So this is our system in brief. Apart from the Ministry of Health and other typical governmental structures, we do have the National Health Insurance Service. This is quite a unique single existing social insurance system that covers literally 100% of the population here in Korea. Next slide, please. And the system was originally established back in 1970s, very slowly evolved into single payer system in the 2000 that has a one risk pool and gives the same benefit package to all. And in Korea, the health system, the private providers are dominant in the supply sector. The public sector is less than 10%. And by the payment system for them is the fee for service basis. With there was a recent introduction of DRG system back in about 7 years ago, but mostly it's a FFS system. Next slide, please. So it is the solidarity the philosophy by principle. So the population coverage of national health insurance has raised since the late 1970s. The government opted to include all the community-wide social health insurance together with the government issued social health insurance, and then they have merged it together in 2000 to form a very big national health insurance service. So this is the basically the coverage rate of the national health insurance during the last 40 years. Next slide, please. So so during this time, the trend, this is the curve that shows the trend of healthcare utilization. The blue curve is the number of the outpatient visits, and the orange curve is the number of the hospitalizations. Of course, the number of the hospital beds has increased rapidly during this period. But if you see the number of the slope of the outpatient visits during this period, the healthcare access has been very easy for those who live in this country to go to the clinics, to go to the hospitals, to go to the emergency department, emergency rooms very easily. Next slide, please. And over these times, so for if we calculate the child mortality rate per 100,000, so this is the curve that has dropped rapidly from 1989 until now. Of course, the UHC stands in between, probably many other factors that's contributed to this. But UHC definitely has made the kids to come to visit the clinics and had to made them to have a better access to health cares. Next slide, please. And if we compare to other countries with some big economies, we stand by at the little right end of the curves, um, next to Norway and Italy and Spain in terms of the life expectancy at birth in year 2017. And if you see the lower hand figure after the introduction of national health insurance in USC in 1989, the life expectancy has raised quite steeper from that point. Next slide, please. So this is like the basic walking through with the history of our national health insurance service and UHC in South Korea. But let's see how it really helped in responding to COVID-19. So we had first introduced the COVID-19 testing in the sense of mass testing, meaning we had a very rapid introduction of the PCR kits, and that has expanded throughout the country in a very rapid manner. So if you remember back in mid-January, the PCR test was approved by our National Regulatory Agency, or MFDS. It's a Korean version of FDA. So they have approved quite rapid manner and then expanded into within the two weeks of period. And if you see the bar graph, this is the number of the tested person, and the line graph is the positivity rate during each days. So in general, so the positivity rate now is around 2% at most. We have about 10,000 people who have been confirmed as COVID. So we have more than 20 times higher number of the number of tests that has been done so far. So this is one of the background that we have scaled up this testing was the introduction. We have this foreground of national health insurance system in South Korea. Next slide, please. So so it is very important to mention the cost of testing the COVID-19 PCRs. So the National Health Insurance has made the cost free for testing in case of close contacts with if there's any epidemiological linkage with the confirmed COVID patients, or if there's any clinical suspicion of COVID-19, for example, pneumonia with unknown etiologies. If there's no criteria meeting for each suspected patients, the patient still can take the test, but it has to pay around 140 US dollars or 130 euros. if the criteria does meet. Next slide, please. And in terms of saving lives, so meaning we have to triage the patients and send the high-risk patients to the hospitals with very well-equipped ICUs and so forth. So we had a quite a fast growth rate of the hospital the beds during the past 17 years. Next slide, please. That has enabled to set up the more than 190 national designated isolation units that along with went with the triage system that sends the lower or middle risk patients to their homes or the residential treatment centers, not the hospitals. Next slide, please. And also from the National Health Insurance Service standpoint, they have made this relief policy back in 40 days ago to cushion the financial blow in the financially vulnerable people. So, for instance, lower 20% of the income brackets were granted 30 to 50 reduction in their premium during the past 2 months. And this quite same applies to the foreign residents. There are about 1.2 million people living in Korea, and their average annual payments is around $800 per year. Next slide, please. So there are still issues that we faced. That we had a quite decentralized triage system in the beginning that had a trouble in allocating the designated hospitals and community treatment centers that had posed some bottlenecks in workflow process that was not very well aligned with the health system. And also, we had like the diverting role of the community health centers to respond to COVID. For instance, they usually had in the normal days when the people who cared about the diabetic patients or hypertension patients had to change their role to respond to COVID patients. So some of these essential service that was provided in these community health centers were diverted. For example, we had about 12% drop in the adult vaccination rate for the pneumococcal polysaccharide vaccines, for instance. Next slide, please. But still, but my takeaway is that I think from our perspective, Korean UHC has provided some help in robust response to the COVID-19 in terms of the efficiency and the equity. Especially when scaling up the PCR testings, and there were some uniform and comprehensive service coverage for the treatment of the confirmed patients. That was also made from the public and private partnership in making the public health policy making that the government and the private sectors has coordinated in the regulating, the system designing, and monitoring and managing, and also provided some leadership in the public health. So this is all that I prepared. Thank you for listening.
Thank you very much, Dr. Jun, for that very insightful presentation on the experience of South Korea. I think there's been widespread recognition of the great work that South Korea has done as a reference in managing the COVID-19 pandemic. We've seen from your presentation how South Korea acted very quickly, responded quickly and with decisive action to address the outbreak through a combination of health systems action combined with public health responses has been able to address the issue, despite the fact, as you mentioned, there has been some resurgence in the last couple of days. I think it's been very interesting from your presentation also to see how a health system that has received considerable investment, political commitment around transformations relating to universal health coverage, forms the basis also for a very strong health systems response. You mentioned how you've transitioned from the national health insurance to a universal health coverage approach, a single payer with high utilization, high confidence of the population. That has really allowed the health system then to surge, scale up and respond in a manner that has been necessary. So thank you very much for that presentation. Now we will pass over to Dr. Robin Nandy, who is the Principal Advisor and Chief of Immunization in UNICEF. So Robin, over to you.
Thank you, Mr. Chair. And thank you, Dr. Youngjun, for a great opening presentation. And I think my presentation is going to shift. It's going to shift and pivot in a couple of ways. We are going to move from Dr. Youngjun's country level experience to a much a broader global perspective, but narrowing down on one particular aspect of essential services within the primary healthcare, universal healthcare package, which is immunization. So I'm going to talk to you in the next 10 or 12 minutes about how we look at the impact of the COVID-19 pandemic on essential immunization services across the board, and in what we are doing about it and what we are recommending countries and governments to consider as they try to keep essential services going. Next slide. So here's the overview. I'm going to talk to you a little bit about immunization services in the context of COVID and some of the interim guidance that had been provided from global level. Our global coordination and tracking of secondary impact on immunization, including various efforts at data collections, tracking of vaccines and related supplies, some update on where we are in terms of modeling the impact of COVID, and some further guidance and next step. Next. So before we start talking about the impact of COVID on immunization, I think it's good to step back and see where we were in global immunization prior to the COVID pandemic. Immunization has been, one of the more successful child survival interventions, successful in the level of scale up across countries. The global immunization coverage, taking a DTP3 or pentavalent, stands in the mid 80s, 86%, and it is higher than most other child survival interventions. However, you'll see from this graph that global immunization coverage has stagnated over the last decade or so, largely because, once you've reached coverage in the mid 80s, your proverbial low-hanging fruit have been exhausted, and everything beyond that point is much more harder to reach, compared to what has been done before. So this is, prior to COVID, we estimate that approximately 20 million children are either unvaccinated or unvaccinated. And this graph shows you the spread across the different WHO regions. Next. Out of the 20 million, we estimate that more than 13 million of these children lack access to any vaccine. So they're what we are calling these days as zero-dose children. These are the children who have not received any dose of vaccination. So they are, and we assume that since they've not received any dose of immunization, they are likely not to have received other child survival primary healthcare services, whether it's services for major childhood killers like pneumonia, diarrhea, neonatal care. These communities lack, maternal obstetric care and nutrition and water sanitation services as well. And over the last several years, within the Global Immunization Partnership, the emphasis has been on addressing these inequities. So reaching the proverbial fifth child in the most underserved communities. Next. So UNICEF, along with the Bill and Melinda Gates Foundation, chairs what is called the Equity Reference Group for Immunizations, and this has been in operation for about 3 years, and really serving as a think tank to drill down, where the issues are and why we have stagnated in terms of coverage. And what our data shows us that most of the so-called zero-dose children, the 13 million that have not received any vaccines at all, and likely don't receive any other health services, live in three types of communities. They're either remote rural, where health services are unable to serve and don't have the reach. They're among the urban poor, largely in urban slum. We all know that urbanization is a global phenomenon, and we are increasing the number and size of global of urban slums, and this is where we see a large proportion of unvaccinated kids. And then the third kind of community is those affected by conflict. We have seen the impact that chronic conflict in countries like the Democratic Republic of Congo, in Central African Republic, we've seen chronic conflict which has hindered health service delivery and therefore coverage. And then we've seen countries that have done well in the past, but as a result of conflict, their coverage dropped, and Syria comes to mind, where coverage dropped within a couple of years to half. And then, of course, importantly, the gender component of immunization, particularly around household decision making, and the role of gender in deciding when and where to vaccinate their children. Next. So as we come up with and we are challenged by the COVID pandemic, we see these equities and we expect these equities to widen. And we, as we looked at it, along with our partners, WHO, Gavi, the Vaccine Alliance, and all the variety of academic institutes and civil society organizations, NGOs working in the global immunization space. We as we looked at the pandemic, we realized that it is inevitable that for a variety of reasons, and some of which we saw in the South Korean experience, that immunization is going to be impacted. There's going to be a diversion of human resources, a diversion of attention, diversion of financial resources to appropriately addressing the COVID outbreak per se. But we were obviously concerned that this would have impact on essential services, including immunization and the disruption. So, soon after the declaration of the pandemic, the World Health Organization, along with ourselves and other global partners, developed a set of interim guidance to address immunization services in the context of COVID. Some of the key parts of this guidance is reaffirming immunization as an integral part of primary health care and therefore universal health care as well. and the importance of continuing immunization services, where feasible, but understanding that there might be constraints and also a need to adjust delivery modalities to ensure that we don't contribute as an immunization community to COVID spread as we deliver immunization. So what does that mean? Continue routine services with physical distancing elements, good hygiene protection practices, as well as protection for health workers. Very importantly, we also recommended temporarily suspending the campaign style delivery of vaccine, which is, short duration, vaccinating large number of kids. It comes with having crowds come together, huge social mobilization that we thought could risk further COVID spread. So a temporary suspension of that. And then guidance on continuing surveillance. Surveillance is going to be key. In fact, immunization surveillance, particularly polio, was repurposed to respond to COVID, the COVID outbreak. Very importantly, from a UNICEF perspective, as the largest vaccine suppliers to low and low middle income countries, are tracking vaccine supplies and making sure that countries don't have stockouts of vaccines. And very importantly, finally, monitor the disruption of services. And we realize that many countries were in different situations. Monitor the impact on their services. That would then guide the intensification of activities post-COVID, or whenever social distancing, physical distancing recommendations are lifted. Next. So as a part of the ongoing response to COVID at a global level, WHO and UNICEF co-chair partner coordination group, which aids information sharing and coordination from countries, coordination of response, resource mobilization, and basically trying to identify what countries need and what level of global guidance is needed. This includes variety of actions which I'm going to talk to you about, but also looking more broadly at what a post-COVID recovery of immunization looks like. Is there opportunities to build back better, reimagine immunization in a different way? Also keeping in mind that there are a lot of activities around development of a COVID vaccine. As and when this vaccine will be available, it would be the immunization program that would be tasked to deliver these to those who need them most. And so, strengthening immunization systems and services is going to be key. Next. So I'm going to give you a quick snapshot of results of a pulse survey that we conducted. And this was a joint effort by the World Health Organization, Gavi, the Vaccine Alliance, and the Boost initiative of the Sabin Institute, along with UNICEF. Next. Next. So this was an attempt at some rough and dirty data on the impact of immunization services. So we had 800 respondents from various parts of the world. Next. And what we saw is not surprising. We have seen already an impact on routine immunization services. They are either suspended or they've been negatively impacted. We've seen that 74 countries across different regions of the world have reported some sort of disruption in immunization services. And we have to be mindful of even the countries that are reporting that they have not had a disruption in service delivery. people have been unable to get these services because of lockdowns, physical distancing recommendations, and very importantly, fear of going to the health center and coming in contact with COVID patients. Next. And campaigns, I already mentioned. We've suggested a temporary suspension of the campaign-style delivery of immunization, and if you look at just cancellation of various campaigns, we have more than 150 million children that are going to miss out on vaccines for the rest of this year. Next. Next. So we also had a qualitative aspect of these services and of this survey, and not surprisingly, a lot of the factors for parents not being able to take their children for vaccination is the fact that they've been challenged in traveling to the health facilities due to various lockdown measures. They're fearful of going out to the health facilities. Outreach services have stopped, and very importantly, health workers are also, fearful of their, the risks they face as they go out to the community to provide vaccinations. Next. Then there were, just to give everybody a flavor, we are also coordinating various modeling scenarios, looking at what the impact of these service disruptions are. The key collaborators are on this slide, includes the London School of Tropical Medicine, Penn State University, Institute for Disease Modeling, and coming to some unified approaches to disease modeling, to see the impact, so that when we are able to reinstate immunization services, we can prioritize them accordingly, based on countries that are most at risk. Next. And the modeling assumption, we are looking at impact 2020, 2021. We are looking at average coverage over the last 5 years, and the prior vaccination efforts, including campaigns over the last few years to ascertain population immunity and risk. Next. I'm going to spend my next couple of slides is the other challenge of actually providing supplies, and I mentioned this earlier, and we are also challenged by huge disruptions in commercial flights. You'll see in this slide, the difference in air traffic in between mid-March and early April, particularly around transport in the African continent. We've seen a lot of cancellation, and that has hindered our ability to move supplies and vaccines to the countries. Next. So roughly, UNICEF-supported shipments to countries have been reduced, by about a fifth, 4/5, so down to a fifth of what we normally would expect for this period. Next. And this you can see, vaccine shipments compared to previous years, it's way down there. So, in this context, really important for us to track vaccine supplies in various countries to make sure that we prioritize the shipments, the few shipments that we have to the right places to avoid vaccine stockouts. Next. So we've put together with WHO and our partners a dashboard to track vaccine stocks in country. The other aspect, besides the risk of stockout, is also monitoring the shelf life of vaccines. It's a perishable commodity with a limited shelf life, and so trying to monitor that very closely to make sure that we don't lose vaccines unnecessarily. Next. So as we went on with our monitoring and our feedback from the countries, we have issued further guidance, and we try to issue these not program by program. So a lot of these guidance are incorporated within broader guidance of essential health services, mainly primary healthcare services. So we have an operational guidance on maintaining essential health services during an outbreak from WHO that we are using, and a specific outbreak on community-based healthcare in the period of COVID-19 pandemic. Next. So in terms of next steps, we will continue as in our partner coordination group with WHO and other partners, the continued tracking of the secondary impact of immunization program. I know other programs like essential obstetric care and neonatal care, child health services are undergoing similar tracking of the impact of COVID. We are looking at supporting countries in implementing the guidance that we have provided, but also case-by-case adaptations where we have to depart from these guidance due to contextual factors and risk factors of the country. Very importantly, and this is where webinars like these are really important, is that there's a lot of good practices in the field that we would like to distill and disseminate so that other countries can follow these good practices. And of course, with good practices comes bad practices as well that we want to avoid. That is worth discussing and disseminating as well. Very importantly, our key message to countries is to initiate planning, ensure supply availability and resources for early resumption of immunization services to catch up on kids with missed doses. Because what we don't want is countries facing a vaccine preventable disease outbreak so as they're recovering from a COVID-19 outbreak. Will have huge resource and economic and other implications besides the implications on the health of the community. And then we also are looking at reimagining immunization post-COVID-19, incorporating obviously in our back of our minds preparedness for deployment of a COVID vaccine when that becomes available, but operating immunization services in a more integrated way. If immunization is dropping, so are other child survivals, coverage of other child survival interventions, and we need to build that up together. Incorporating physical distancing, COVID will be with us for a year or two. We would need to adapt the way we operate. We also see the economic impacts of COVID. Countries are going to have less disposable resources, and we are looking to see how we can have better efficiencies, not only for immunization, but for a broader set of primary healthcare and universal healthcare services. Next. And I'd like to acknowledge that, while I presented this on behalf of UNICEF, I have to acknowledge that the contribution of WHO, the Gavi Vaccine Alliance partners, and Save and Boost initiative. Thank you.
Thank you very much, Dr. Nandi, for that excellent presentation. I think looking at it, there are an enormous amount of people living in conditions of vulnerability, as you mentioned, in remote rural areas, the urban poor, and conflict zones, and obviously we have the gender determinants. I think your message has been very clear in terms of how vaccination is a core part of primary healthcare. Primary healthcare is a strategy with highly resolutive first levels of care that have to be able to respond to the needs of a population in the community where they work and they live. I think some of your messages and the information we've received on the interim guidance coming out of WHO with the partners, UNICEF, the messages around coordination is critical, and we here at PAHO have also seen the enormous supply disruptions that are impacting not just the immunization programs actually, but the HIV, TB, malaria programs as well in terms of global shipments of medicines and supplies. But I think your message is a message of hope in terms of how can we envision a post-COVID-19 era and building back better and fully ensuring the integration of vaccination immunization services within primary healthcare. So thank you very much for that presentation. We'll now turn to Dr. Wen Zhu of the National Immunization Center of China and the Center for Disease Control in the People's Republic of China. Over to you, Dr. Wen Zhu.
Okay. Okay, thank you, Chair. Hello, everyone. I'm very happy to be here to introduce the China appearance of the immunization surveys during COVID-19 epidemic. Next, please. By the main contents of my presentation is impact on immunization surveys due to the pandemic and strategies for immunization surveys during epidemic and also including the technical guideline of catch-up vaccination at recurring stage. Next, please. In this slide, there are two figures. The map shows regional distribution of our community-reported cases in China. We can find Eastern and Central China reported more cases, and Hubei province is the epidemic center of this epidemic. The bar chart shows that up to midterm, there were only 140 cases receiving treatment in hospital, and totally 82,000 confirmed cases have been reported in the whole China, and 4,633 dead cases in the whole China. These days, there were several cases reporting of COVID cases. For example, in May term, only 10 local cases and 7 imported cases reported in the whole country. Next, please. By January in 2020, China launched the highest public health emergency response across the country. This is a level 1 response, very high level response. During the epidemic, at the early of the epidemic, 80% of the EPI clinic suspended the vaccination service. From this table, we can find the vaccination dosage change before, during, and after the epidemic. We take the vaccination dose of December 2019 as a denominator, as a baseline data, so we can compare the vaccination dosage change in January and February and March. We can find that for the whole China, in the January, only 70% vaccine dosage. And in February, the proportion decreased to 26%. In March, the epidemic was under control in China, so some provinces restarted the vaccination service. The vaccination service recovered a normal level, so the vaccination dosage can be 104% of the dosage of December in 2019. Next, please. China CDC released a reference guideline for vaccination service during the epidemic. During the epidemic, 4 vaccines, including hepatitis B vaccine, BCG, rabies vaccine, and tetanus toxoid, required to be administered in clinics. We know hepatitis B and tuberculosis are the priorities of infectious disease in China to be controlled. So the best benefit will be gotten if we provide the vaccination for the newborn as early as possible. So these vaccines are administered in obstetric department of a hospital in China. Rabies vaccine and tetanus toxoid are required because we would like to save life when they are administered in specific clinics for rabies prevention and control and wound treatment respectively. Next, please. We take the example to describe the vaccination dosage change in different provinces. From the left, the chart, we can find in Hubei province. This is the epidemic center. So we can find that from the January 22 to the middle of March, with the vaccination service stopped. So the vaccination dosage reduced very low level after the middle of the March. So we started the vaccination. So the vaccination dosage increased the normal level. The right chart is from Gansu province. Gansu province is a very low risk area. So we can find it in only from the January 24 to February 15th. They stopped the vaccination service. Overlapped with the Spring Festival, and so that is to say that very short time to stop the vaccination service. Then after the February 15, the vaccination doses increased the normal level with the similar with the same time of last year. Next, please. Central government required in China required that all provinces should conduct risk assessment for epidemic. Ministry of Health also asked the clinic to provide the immunization service based on the risk assessment. No epidemic or there is an imported outbreak and it had been completely controlled. All imported cases have been isolated. Close contacts have been placed under medical observation, and the risk of COVID-19 outbreak is minimal. This district is regarded as a low-risk area. So in this area, the routine immunization service should be provided by the clinics. For the middle risk area, if there is an imported outbreak, but it is not clear whether it had been completely controlled. Cases have been isolated, but close contacts are not all found, or medical observation is not in place. There is a great risk of virus transmission. In this is regarded as a middle risk area. So in this district, vaccination service may be provided carefully. So depend on the county health department's decision. For the high risk areas, the outbreak has spread locally, or there has been a second generation of cases. In this district, the EPI clinic shall stop the vaccination service. Next, please. During the catch-up campaign, the vaccination campaign, the target population included the children who delayed vaccination due to the epidemic, and the children who missed the vaccination during the epidemic. Totally, in China, there are almost 60 million vaccination doses delayed or missed due to the epidemic. All doses were required to be completed within 2 months after initiation of a catch-up vaccination. Each province has a different date of the restarting vaccination service. At least 90% of the delayed and missed doses completed on time. Each province. We should evaluate this indicator at the provincial level. After the catch-up vaccination, the coverage rates should reach over 90%. Next, please. We have 3 ways to find the unvaccinated children and the children delayed vaccination. Firstly, locate the children accurately through immunization information system by sorting out vaccination status. Secondly, find the unvaccinated and unregistered children through house visit with the help of the community, township, and the village leaders and team members. Thirdly, find the children through telephone and WeChat. And so next, please. After we locate the children who delayed or missed the vaccination, we should make appointments for vaccination with the parents through IIS or APP to decide the time, vaccination time. Vaccination time should be decided during the appointments through telephone, message, and WeChat to control the number of children daily service in clinic. Vaccination doctors should check health condition when they make appointments with the children's parents. If the children are bad, the health condition are not good, so the vaccination doctor should delay the vaccination appointment for the parents, for the children. Next, please. There are some precautions for the vaccination data and the parents during the COVID-19 epidemic. For the doctors, they should make vaccination appointments with the parents and to avoid our crowd gathering. They also should take self-protection measures. For example, use wear mask, work clothes. They also should take a temperature for the children and the parents at the entrance of the clinic. For their parents, they should also pay more attention to make vaccination appointments with the clinics. No appointments, no vaccination now in the clinic. Know the arrangement of the EPI clinic, and when they go to the clinic, they should wear mask and take a temperature before entering the clinic. They also needed to learn how to handle the mild reaction after the vaccination for the children at home. Next, please. These pictures show how to implement the catch-up vaccination in some clinics. For the doctors, they should make the screen the unvaccinated and children and the missed children through the IIS and also house visit. I also make the appointment by telephone. And before they enter the clinic, they should wear mask, and the doctors should take the temperature for the children and parents. Also, the clinic should control the number of the children and the parents to avoid the cross contamination. Next, please. There is a double burden for the current vaccination service in the EPI clinic, because they should conduct catch-up vaccination. They also should conduct a normal immunization service. At the same time, for the epidemic, COVID-19 epidemic, they should make an appointment for the vaccination so as to control the number of the children and the parents in the clinic. So it's very difficult to complete the catch-up vaccination campaign. So we recommend the measures to speed up the catch-up vaccination. Include the clinic should prolong the times and the dates for immunization service. For example, if they work for 4 hours one day before, now they increase the work times to 8 hours or 10 hours one day. And per week, maybe they only work for 3 days. Now they can increase the 5 days or 6 days per week. They also work. They also ask to provide the service in weekend. We also recommend the clinic add a vaccination space and increase vaccination doctors to provide the service for the children. Finally, we also recommend simultaneous vaccination with different vaccines and the combination vaccines for the children. So this action can speed up the catch-up vaccination campaign. Next, please. So this table shows the progress of the catch-up vaccination in China. During the serious epidemic of China, 83% of the clinics stopped the vaccination service in the whole China. At the epidemic center of Hubei province, the red line, almost stopped the immunization service in all clinics. But in Beijing and Shanghai, they have a good health system. So they can very small number of the EPI clinic stop the vaccination service during the epidemic. At the early of the March, the epidemic was controlled, and so some provinces started to provide the vaccination service for the children delayed and missed vaccination. After 65 days of immunization suspension, Hubei province restarted the vaccination service. Up to now, in the whole China, 99% of the clinics recovered routine immunization service. About 70% delayed and missed doses of vaccination. That means 41 million doses have been administered to the children in the whole China within 1.5 months of the catch-up vaccination campaign. 8 provinces completed over 90% of the doses. But in Hubei province, we can find that only 45% of the doses have been provided. It needed 1 more month for the completion of the catch-up vaccination. So this is this data is as of 7 May 2020. Maybe the percentage will increase after the least 2 days. Next, please. After the catch-up vaccination, we are planning to conduct evaluation. We wanted to conduct the two evaluation activities. One is the on-site evaluation. The provincial CDC selected the three counties, 3 communities per county to evaluate the catch-up vaccination. That's provincial CDC staff, we all go to field to investigate the children to check the immunization status after the catch-up vaccination. China CDC will carry out the evaluation on catch-up vaccination based on the immunization information system. We will select the 200 EPI clinics at random to get the children's immunization data and then check the vaccination status, so we can evaluate the impacts of the COVID-19 epidemic, and also we can evaluate the progress of the catch-up vaccination and routine immunization service operation. How is the routine immunization service? We plan to conduct this evaluation during June 15 to 25. Next, please. Finally, in summary, the COVID-19 epidemic has a huge influence on immunization service in China. 80% of clinics suspended vaccination service for 1-2 months during the epidemic. All clinics were asked to provide service for the first dose of the hepatitis B vaccine, BCG rabies vaccine, and tetanus toxoid during the epidemic. All countries were asked to conduct risk assessment before providing immunization service. All clinics had to balance catch-up vaccination and routine immunization service. In our country, strong immunization system helped to ensure that despite the pandemic, catch-up vaccination campaign and routine immunization service could be managed. Next, please. So that's all. Thank you for your attention. Thank you. Thank the UNICEF China office invitation for attending this meeting to present the China appearance to other colleagues. Thank you much.
Thank you very much, Dr. Wen Zhu, for the overview on how China has approached the issue of ensuring the provision of immunization services from the context of the COVID-19 pandemic. I think the approach that you have presented here today is really of high relevance for all countries, an approach based on risk, on need, on science, on evaluation, and I think it's been extremely interesting to see how in this practical experience how the country has been able to ensure coverage of these essential immunization services within this context. Okay, colleagues, we're going to now move to the question and answer part of our webinar. We have essentially 10 to 15 minutes for questions and answers, so I'd like to invite any of you who have not posed a question to do so in the chat again. We do have a number of questions that have already come in, so what I'm going to do is to try and organize the questions, to cluster them if possible. I'd invite all the panelists to come online again and share your videos so that we can have an interactive session here. I'm going to start with a more general comes in from Rhodes in Zlovu, and I hope I pronounced your name correctly, Rhodes. And it's really around the issue of essential health services within the context of primary health care and the pandemic. And so with resources being limited for COVID-19 in the developing world, what are we really putting in place to ensure delivery of primary care services without exposure, ensuring protection of our health workers against COVID-19? There is an issue of trust here that Rhodes is mentioning. How do we restore trust within our communities to ensure that the communities will seek those services when required, not only during the pandemic, but post-pandemic? So I'd like to pose that question to the panelists. And perhaps Dr. June, given that you started the presentations, I'll invite you to comment on that first, if I may. You'll have to activate your microphone.
So sorry. So sorry, yeah. So from my understanding, so let me just illustrate what we have gone so far from South Korea. So from the essential health service standpoint, for immunization especially, that we had like it dropped about 2 to 3% of all vaccination coverage for like DTP5, MMR2, like IPV4, so forth. So those has dropped about 2 to 3%. I think it is little less than what is experienced in other countries. That's for childhood immunization. But for adult immunization, as I have mentioned before, the drop was huge. Like it was 12% point for the elderly PPSB 23. One of the reasons was that most of the adult vaccinations are given at around 100,000 private clinics across the country, whereas most of the elderly 65 years older PPSV vaccines are given at the public health centers. That is only 253 public health centers across the country. So we see the gaps here. So if we cannot mobilize the civil society, including the private clinics and private health care sectors, we wouldn't really be capable of keeping up with the essential health services. From our standpoint in Korea, that we have experienced here, that most of the, although there were some drops for the childhood immunization coverage, it was small relatively to the adult vaccination, which is mostly confined to public health sector. So we find a little bit room for us to tackle in response to COVID-19, that we had a good in the area that we had a good public and private partnership. We had a little better response to in keeping up with our essential health services.
James, you're on mute, I think.
Thank you. So Dr. Wenzhou, how did you manage the issue in China of community outreach and building trust within the communities to come back within the health services, or did you organize community health workers to go out into the community and ensure the immunization levels, and also other essential health services, if you want to address that?
Thank you. For the community health worker, I think for the epidemic control prevention, this epidemic, community health workers played a very important role. They conduct the epidemiology investigation, help investigation, also control also register the population, also give the people the help, have so many help. For the immunization, they also plays a very important role for the immunization for the unvaccinated, unvisited children. The community health system, community health workers, they would find they would like to find that. It depends on their community health system to find the unvaccinated children and the missed children, because the community workers, leaders, and the health workers, they know the details of the unvaccinated children and the missed children. So it's very important for the community health system for the epidemic control, and also including the immunization service in China. Especially in China, we made successful control and prevention of epidemic. It depends on the community health system and the community health workers, community staff, and other staff. I think we believe for the catch-up vaccination, we also depends on the community health system and the health workers and the other peoples. So thank you.
Okay, thank you very much. Dr. Nandi, within that context, so the guidelines that UNICEF, the interim guidance the UNICEF has developed with WHO, what is the focus of those guidance in terms of the focus on community health? There was a specific question here also on whether we are suggesting that we focus on maintaining current coverage levels managed within the concept of fixed posts, I presume, delivery health services, and just assuming that we're going to have dropout rates, as we saw from the presentation of China, and how we deal with that catch-up. So what does WHO and UNICEF say about this?
Yeah, thanks, James. Thanks, Chair, and thanks for the questions, colleagues. There's a lot in these questions, and obviously, you know, it's a complex answer. So, you know, obviously we have to issue guidance that fall within the realms of reality and practicality in terms of what we can do. And I think that was our approach, is to issue our interim guidance in a pragmatic way, understanding that immunization services will be disrupted. So I'll take the second question first. Is you know, the decision to recommend suspension of campaign style delivery of immunization was a difficult one to take for the reason you mentioned, but on the other hand, we did not want to also contribute to the spread of COVID transmission, as well as put health workers in at undue risk for infection through COVID. So these are interim guidance. They're meant to be revised. Obviously, our approach was that a short-term disruption or suspension of campaigns would be the right thing to do. But obviously, the longer the disruptions continue, the more difficult it gets to stick to this guidance. And that's why you'll see on one of the slides is our approach is to work to countries to implement the guidance and make adaptations, you know, based on the context, based on risk assessment, and so on and so forth. Obviously, campaigns, the practicality of conducting a campaign when you're in the midst of a COVID outbreak, which is already stretching resources, is it possible to conduct a high-quality campaign in a safe manner? So, for example, polio campaigns are house-to-house campaigns using a multi-dose vial of an oral vaccine that is getting very close to the faces of kids, in the community, and we had to step back, on that. But I think a lot of the answers were provided by Dr. Wen Zhu when he talked about the China experience and how you stratified the various regions in terms of impact of COVID and risk of vaccine preventable diseases, and tailored the interventions to those a particular area. And that's, I think, where our more nuanced guidance, our next iteration of guidance are going to come from. you know, there's the epidemiological considerations and the risk consideration, but then there's the practicality of the mitigation efforts. What is the ideal delivery modality that is compatible with the social and physical distancing and mitigation efforts? In a lockdown scenario, it is impossible to conduct a campaign, so we have to tailor this accordingly. On the other question on resources, we do expect a decline in resources. Economies are taking a big hit. That will impact the availability of domestic as well as global level resources. I think it's more imperative than ever before to now club all our resources together, whether we're talking about Gavi, the Vaccine Alliance, the Global Fund for AIDS, TB, and malaria, and the global financing facilities, the 3Gs, the Global Polio Eradication Initiative, to come together, pool our resources, and provide integrated primary healthcare services. We have to look for efficiencies. So I know there was a question on building better. What does that look like? Is that we try not to go disease by disease, antigen by antigen, but to provide a comprehensive uh, package of services, which we have seen in the past also serves to build trust within the community. We have seen through polio campaigns going multiple times with a single antigen, you know, raises questions, raises community questions. So I think these are efficiencies. We have in the past, delivered routine services, even having, mothers and children, waiting in closed areas for several hours before a health worker decides to open a vial of vaccine. I think a lot of these delivery modalities, when we incorporate physical distancing, I think, it could have a positive impact on the quality of services.
All right, so thank you very much. That's a nice segue into my next and probably final question that will cluster a number of comments and questions coming in from the participants, and that's about the future in terms of the lessons that we are learning from this, in terms of our health systems response capacity, how we structure and how we organize our systems, and how we use this experience to ensure that we really have health systems moving towards universal health coverage in the future. And so the key question is, aside from the international development agencies and the international financing institutions, what do governments have to do to ensure that their health systems are really better prepared and have future capacity in the future to be tackling with a pandemic, with a natural disaster, but to be able to ensure that their health services are highly resolutive, they're comprehensive, they're expansive, they're of quality. And so within this context, looking at where we are and beyond COVID-19, what do health systems need to do? And linked with that, how do we ensure social protection in health? Maybe I'll ask, given the focus of your presentation, Dr. June, on UHC and the National Health Insurance, maybe you can provide some comments from South Korea on that.
Right, so let me just, so there have been some reforms that has been taken place in Korea over the past 15 years, including the DRG and like the HTA, the transitioning from the multi-fund system to a single-payer system in the year 2000, and also around 1999 there was a separation of dispensing from the prescription. Before, just doctor's office just dispense the drugs. Now it's not happening anymore. So those are some kind of reform that has been taken place in South Korea. But there are still lots of issues that is being remaining. For example, we do have the uniform benefit package, but it's not like the comprehensive service that are covered within the package. So, for instance, the out-of-pocket the coverage is around 38% on average, still very high, and there are some equity concerns with this high out-of-pocket coverage, because most of these COVID patients who required high demand of medical resources who gets admitted to the ICUs, they are quite so to speak, the elderly people with who has resources to pay for from their out of pocket. But in the case of certain outbreaks or certain diseases, in case if there's the disproportionate damage to those who cannot afford to pay for this, it's very hard for them to make the adequate healthcare access. So that is an issue that we have. And also that we have the growing number of the private health insurance. We have estimated about 90% of households now has the private health insurance. So that also in turns translates that our social health insurance system is not fulfilling the needs of what people are needing, so to speak. And those are the issues that we face, that we have now. There were some like the positive side of our fragmented system, that even if there's one system that makes failure in some instance, the other system can back it up. But there are still the privatized delivery system that has issues in terms of coordinating the whole system all together to place into the for the increasing the financial burden of this for the households over time. Yeah.
Okay, that's very interesting. Thank you. And from the perspective of China, Dr. Wanzhou, so what is your perspectives in terms of lessons learned and how we can really increase resilience capacity moving forward in health systems in China?
Very good question, but I think it's very difficult to respond to this question. As we know, for the 17 years ago, the health system was criticized by the society and the public because of SARS outbreak. But for this COVID-19 outbreak in China, the Chinese health system in China also criticized by the public, especially for the public health system. So actually, the epidemiologists and the staff of the public health did so many work to conduct the investigation, epidemiological investigation, and also can make a medical observation for the contacts and the other people, and collect the samples and test the samples, and also follow up the cases. We health system play very important roles. Not include also including the medical treatment in China. So you know the news, the medical staff went to Wuhan for to fight against the COVID cases, regarded as a war or a campaign. So, but finally, for the public health system, lost the public trust. So, I think I don't know the reason how to recover the trust, public trust for the public health system in China. So during the epidemic, China CDC also was asked to develop the proposal of the reform of the public health system. So we don't know how to develop, what's the direction of the public health system. So, but I think actually we have we did very well in the epidemic control and prevention. But I think for the public health system is very good, is excellent in China. So we should know the reason why we lost the public trust. We need the public's confidence in the health system. So we also, for the public health system, we maybe need more resources. The central government, we maybe need to allocate the more resources to the public health system. For the medical system, so the public health system is very weak. So we in the China, this is a real situation. So we needed to improve the public health system. Yeah, I think to fight against infectious disease. Thank you very much.
Thank you very much. And the final word to you, Robin.
Yeah, James, I'll be very brief in the interest of time. Really important question, and really important for us to get our heads around it. If we are looking at the impact of COVID, we are seeing a disproportionate negative impact on the more underserved, more disenfranchised populations across a variety of countries. So it is these communities that are most vulnerable. So I think, the first thing is, identify, where the coverage gaps are and where the underserved populations are. I mean, this should be in the back of everybody's mind, whether you're working in the health sector, other associated sectors with very important, the social protection sectors. And this is where greater linkages between sectors like health and social protection will get us to these underserved and marginalized population. My second point is the furthering the agenda of primary health care towards universal health care. And I think the Korean experience has shown, the South Korean experience has shown, what a robust universal healthcare system does in terms of resilience and ability of a country to address and recover from shocks like COVID-19. So I think, and the third piece of that related to primary healthcare is the importance of community-based healthcare. I mean, it's something that we have talked about for several decades, but we have still yet underinvested in it, and we have failed to institutionalize it within the health system of various countries. And you know this more than most, Mr. Chair, given your role on health system. And it's finally, I hope that, we always say that you don't let a crisis go to waste. And I really hope that our experience in COVID-19 can, ensure that we are more prepared for the next one that comes along. Because what we can rest assured that COVID-19 is not going to be the last global health threat that we face. And community-based structures linked with CSOs and other non-government entities is extremely critical in maintaining the trust. And that's where the rubber hits the road, and strength there will ensure that we are we are better prepared in the future.
Thank you very much, Robin, and thank you to all our panelists this morning. It's been a really wonderful session. We really have had the opportunity to see hands-on practical experience of two countries, South Korea and China, in managing this complex balance that needs to be achieved in ensuring the provision of essential health services within the context of a COVID-19 pandemic, recognizing the importance that it's not an either-or choice, that it's a must in both cases, but obviously doing it in a manner that is risk-based and is there to protect the population and, of course, our valued health workers. And we've seen from the perspective of UNICEF how UNICEF is working with WHO and with partners in examining the global context around this important issue within the context of immunization, working on interim guidance, examining how partners can come together to to provide that guidance to low and middle income countries and how they deal with this. I think there's a couple of lessons that we can take from the participants and from the experiences we've seen this morning. The first is the point that I've made. It's not an either or approach. It's not a dichotomy. We need to be able to respond to the pandemic and yet reconfigure, reorganize, surge our health services capacity to be able to ensure the provision of all essential health services, not only in immunization, but in sexual reproductive health, in the control of other infectious diseases, in non-communicable diseases. And how we do that, it really needs to be focused on examining the various scenarios we have, reorganizing and restructuring and remanaging our health system. The second lesson that we've taken from this discussion is that when we talk about the future, we have the guidance, we have the orientations, we have the mandates that are necessary to really strengthen the capacity of our health systems. It's not just an issue of coverage, ensuring the inputs necessary for health systems, but it's really about breaking down the access barriers to health, removing issues associated with financial barriers, geographical barriers, cultural barriers, so that we reach all the populations that we need to reach in terms of essential health services and in fact all health services. I think the third element of the response we've seen here this morning is that primary health care is the way forward. A strategy based on primary health care with a strong, resolute first level of care that provides comprehensive access to health services, that meets the needs of populations, that is based on a strong community health program, is really the way forward, and it's something that we really need to strengthen moving forward. The fourth point I think we need to take from this discussion is around health financing. We are entering probably a sustained global financial recession in which our social sectors are going to be directly impacted. Within that, education and health will be probably the two sectors that will be particularly impacted. But we need to make the argument that if we don't focus on a counter-cyclical investment in health, in public health, and in our health systems, we will in fact be shooting ourselves in the foot, so as to say. If we don't invest in our health systems, well, then we will not learn from the lessons of this pandemic, and we will find ourselves in a situation where we are not prepared for the next pandemic. What we need to be able to do is to ensure resilience in our health systems, and so that our health systems are well prepared, not just to provide health services within the context of COVID-19, but to ensure comprehensive health services that meet the needs of the population. This does not occur in isolation. Health is not something that occurs within a specific silo. It occurs within a broader, much broader policy approach around social protection and health, and around social development. And so we need to continue to work in building resilient health systems, providing essential health services within this context, and remembering what our overall objectives are to ensure the 2030 Sustainable Development Goals. Colleagues, we're going to leave it there. I'd like to remind you that we will follow up on some specific questions that were posed within the chat. We really do want to urge you to join the online community dedicated to this initiative, and in particular to join the next webinar, which will be hosted by the Social Protection Organization on the impacts of COVID-19 on care politics, some of which we have already covered in this discussion. So don't forget to register for the next webinar. I hope you found this webinar extremely useful. I will sign off now, just thanking socialprotection.org and all our panelists for their work, and a particular note of thanks to Karine for her facilitation of this wonderful discussion. So with that, I will leave you. Thank you very much, and goodbye.
Thank you, Chair.
Thank you.
Thank you very much.